Assalamu alaikum and good afternoon, everyone. Thank you very much to the forum for inviting me here and providing me with this wonderful opportunity to be part of this academic session. Just quickly moving to the topic, improving the outcomes in hypertension management. What is the role of early start of combination therapy? My name is Dr. JUNAID and I am an interventional cardiologist. Hypertension is a menace. We know lot of work has been carried out for the betterment of hypertensive patients, and lot more is being done. So every day there is a new update, and every other day there is something new for the physicians. The global prevalence of hypertension, world population we know is around 7 to 8 billion according to WHO statistics. 1.28 billion are hypertensive, and ironically only 42% of these patients are diagnosed and treated for their hypertension. Approximately, which constitutes approximately 1 in 5 adults, that is 21% of the hypertensive patients who are having their blood pressures under control. It's a major cause of premature death worldwide, and one of the global targets for non-communicable diseases of WHO is to reduce the prevalence of hypertension by 33% between year 2010 and 2030. This graph itself is self-explanatory and tells us that there is 42% of the population whose blood pressure is being not treated or is uncontrolled. 40% are almost totally untreated, and 18% of those who are being treated for hypertension have their blood pressure under control. Importance of blood pressure control is that the cardiovascular mortality risk doubles with each 20 by 10 millimeter of increment in the blood pressure. So if it's a one-time risk for those who are having their blood pressures under control, 115/75, the risk goes to 8 times for those who are having their blood pressure 175 systolic and 105 diastolic. The situation is almost similar in Pakistan. 37.3% of the adult population is hypertensive. 36 millions among 38.7 millions have their blood pressures either not being treated or not being controlled very well. No body organ is immune of the detrimental effects of hypertension, we all know. So if it's the vascular system, there is accelerated atherosclerosis leading to different hazards and different adverse outcomes of atherosclerosis. As far as the heart is concerned, it leads to hypertensive heart disease, heart failures, and cardiac deaths. The kidneys, they develop hypertensive nephropathy. There will be talk on strokes and management of stroke, which is actually a complication of hypertension. There will be talk by Professor Qasim Bashir soon. It leads to hypertensive retinopathy and as well as peripheral arterial disease. What are the various reasons for not achieving the desired blood pressure control? So looking at this graph in the descending order, the most common reason is that the patients are not compliant with the treatment. So what is the reason why patients are not compliant with the treatment? There must be one or more reasons. The second number is that the patients cannot tolerate side effects associated with increasing drugs. And the third cause is monotherapy is not effective in hypertension treatment. Now, one reason is also that the combination therapy is not started earlier, and 35% of the patients are in this group. Hypertension, lifestyle modifications helps controlling hypertension. The weight reduction, if there is a 10 kg weight loss, it can lead to 5 to 20 millimeter of mercury, 5 to 20 millimeter of mercury drop in the blood pressures. Adopting a good DASH diet plan can reduce the blood pressures by 8 to 14 millimeters of mercury. Dietary sodium restriction can also be helpful by decreasing 2 to 8 millimeters of mercury, and daily physical activity can reduce the blood pressures by 4 to 9 millimeters of mercury. This is a nomenclature of hypertension proposed by different societies. So the consensus are that the normal is less than 120 and less than 80 millimeter of mercury diastolic blood pressure. The elevated blood pressure systolic is 120 to 129. Stage 1 hypertension is 130 to 139 millimeter of mercury systolic and 80 to 89 millimeters of mercury diastolic. Stage 2 is 140 and above and systolic, and 90 or above diastolic. Now, if the blood pressure is more than 180 and more than 120, it will be labeled as hypertensive crisis. This is the proposed therapeutic management plan by different societies again. The blood pressure targets for treatment by the American College of Cardiology, AHA, is less than 130 and 80 millimeters of mercury. The ESH and European Heart Association, it recommends less than 140 millimeters of mercury, but close to 130. And for the ISH, International Society of Hypertension, for those who are having age less than 65 years of age, less than 130 by 80, and 65 or above, less than 140 by 90. So 130 is a key figure basically. Implications of hypertension guidelines in daily practice: start early treatment to achieve desired blood pressure controls. Guidelines recommend starting treatment with combination therapy, and combination therapy get better patient compliance with lesser side effects. Now this is a concept, this is an important concept. I have deliberately put this slide here. This is therapeutic inertia. So what is therapeutic inertia? Therapeutic inertia means that your patient, his blood pressures are not under control, and you note that really this is happening, that the blood pressures are not under control, but somehow the physician is not convinced to up titrate or to initiate another drug. So this will be labeled as therapeutic inertia. This will down the line result in more and more cardiovascular hazards in these patients. This is a representation of the same therapeutic inertia and its importance. So less than 120 millimeters of mercury, it's good control. 120 to 139 millimeter of mercury, it's optimal control, and 140 or more is bad control. So those who had no inertia, this was a 10 years follow-up study. So those who had no inertia, the blood pressure in majority was an optimally controlled blood pressure. Whereas a number of patients had good blood pressure control as well, less than 120 millimeter mercury. Whereas those who were whose physicians were practicing this therapeutic inertia in their practice, 140 millimeter of mercury poor control was seen in significant number of patients. Somehow there was optimal control in good patients, but a significant number of patients had poor blood pressure control in these patients. So the physicians need to know the importance of therapeutic inertia when the blood pressure medication needs to be up titrated, when new blood pressure medication needs to be added. So this is we are going to discuss today. Need for fixed dose combination. These are different trials, landmark trials, which highlighted the importance of fixed dose combination therapy. And we came to know that up to 80% of the patients need at least 2 drugs to reach their blood pressure control in these landmark trials. Significant cardiovascular risk reduction is observed. There is 26% reduction in the bad cardiovascular outcomes if the patients are started on started on combination therapy than those who are on monotherapies. Rationale for fixed dose combination: you can see that those who are on monotherapy, hardly 20 to 30% of the patients could reach the blood pressure targets, whereas those who are on combination therapy, 75% to 90% blood patients had their blood pressure under control and in the target levels. Again, the same slide. So how can we combine different drugs? This is a physiological formula. The blood pressure is equal to cardiac output into stroke volume, and the cardiac output in turn is systemic vascular resistance and into heart rate. So if we are devising combinations, if we are devising a formula to treat our patients with more than one drug, so we have to manage, we have to fix all these numerical numbers. We should be working on more than one pathways to treat the blood pressure and to advise blood pressure medications. If we are prescribing medicine, more than one medicine which is working on a single mechanism, it's not going to help us. So this is the reason why I put this diagram here. Observations are key factors to ensuring compliance in the blood pressure therapy. Once daily dosing is being preferred by majority of the patients are hypertensive patients. They are many of them, they are suffering with comorbs like diabetes, ischemic heart disease, peripheral arterial disease, neurovascular diseases, and somehow they are taking a number of medications. So just to cut down the pill burden, once daily dosing, favorable side effect profile, should be having good efficiency, round the clock blood pressure control, protecting target organ damage, and obviously the economy. Strategies for combination therapies. This is a widely described diagram and widely practiced. So the solid grids are those which are favorable combinations. So combining a thiazide with angiotensin converting enzyme inhibitor, combining an ACE inhibitor with the calcium channel blocker, combining a calcium channel blocker with the ARB, and the red line that this combination should not be practiced, and ARB should be avoided to combine with the ACE inhibitors. I will just skip this slide. This is 2030 ESC guidelines for the management, and it mentioned that whenever possible, use of fixed dose combination should be preferred because simplification of treatment carries advantages for compliance with the treatment. So among the various medicines available, with drugs available, different armamentarium to treat hypertension, we have a number of class of antihypertensive drugs. As far as the ARBs are concerned, valsartan is the most documented ARB, and a wealth of data is available through many trials. Value, Valiant, Navigator, you can see these are all landmark trials. So far, more than 50,000 patients have studied with valsartan, and it has proven its efficacy in management. So coming back to the same diagram, and if an ARB is combined with a calcium channel blocker, there is a superior blood pressure lowering efficacy. You can see that amlodipine, if being given alone, it can lead to blood pressure control by 16.9 millimeter of mercury. Valsartan alone can reduce it only to 14.5 millimeter of mercury, but if both are combined, we can have a 23 millimeter of mercury blood pressure reduction. Another beauty of combining an ARB with the calcium channel blocker is that if given alone, the calcium channel blocker lead to vasodilatation, but it can lead to edema. Looking at this diagram, there is dilatation here but not here, and this leads to edema at this end. This is the capillary junction, and the arterial end and the venular end. So if we combine an ARB or an ACE inhibitor with the calcium channel blocker, there is venodilatation as well as arteriodilation, and the effect is less edema in this combination. And the same diagram. So summary is controlling hypertension reduces adverse cardiovascular outcomes. Majority of patients require 2 or more drugs to achieve their blood pressure control. The use of single pill combination therapy can further improve blood pressure control and reduce cardiovascular morbidity and mortality. Combination therapy is now recommended in most of the hypertension management. When practicing a combination therapy, how can we, we can manage our treatment medications? We can start with the 2 drugs. The American College of Cardiology and American Heart Association, it recommends that if the blood pressure is more than 20/10 millimeter of mercury, the target level means that if the systolic blood pressure is more than 20 millimeter of mercury and the diastolic is more than 10, we can go straight forward with two drugs, and otherwise we can start with single drug, and we can up titrate it to the maximum dose, and when blood pressure is not controlled, we can add a second drug and then up titrate it. The other regime is that we can go straight forward with the 2 drugs, and we can keep on up titrating both combination. The third is that you start with 1 drug, and before reaching the maximum dose, you add the second drug, and then you keep on up titrating both drugs. Thank you very much.